We have someone treating or you can-
No, you can sit wherever's open. Last couple of set up at that end of the table, but wherever is free, we can get, there's not a chair there. We can go with the center one there, or we can add one to the corner.
Recording in progress.
Just about, I just need to move the room. Hold on.
You would state your name and where you're from and basically limit your comments to 3 minutes. We appreciate that. And if you are not able to do it that way, you can actually email a comment or question to John. So I'd like to move into consent agenda.
Move approval of consent agenda.
Any discussion? All in favor? So moved. Call to order, points of order, points of order. Hearing none. Is Michelle on yet?
So Ron, this is Shanna. They just said the public are unable to join the meeting.
Dear John.
It should all be in there. We have 18 attendees. Dr. Anderson.
There is Michelle.
Okay, Michelle, we're gonna hop right into yours right away before you get called away.
Thank you. Thank you guys so much. So I have the credentials report for Dr. Lemmy, who's traveling at the moment. Let me just get this door. For initial appointments, for credentials for this past month, we have Dr. Jin Young, OBGYN, as a locums for provisional privileges. We have Dr. Wen, also an OBGYN locums for provisional privileges. And Heather or Connor, thank you for posting those on the screen share. We have nurse practitioner Jamie Riddell, neonatal nurse practitioner for provisional privileges. We have PA Mitchell for the outpatient clinics for provisional privileges. And that also includes his set was for first assist privileges as well, which he has a lot of experience in. We have Dr. Areta as a telehospitalist for provisional privileges. We have Dr. Gill, also telehospitalist for provisional privileges. And Dr. Hadakia, a telehospitalist, provisional. Dr. Kwan, telehospitalist, provisional. Dr. Manny, telehospitalist, provisional. Dr. Patel, a telehospitalist, provisional. And Dr. Babaki, a telehospital, provisional privileges. I'd like to Make a motion.
Approval of initial appointments.
Second.
Moved in second, any discussion? All in favor?
Aye.
So move.
Thank you. For advancements, we have Dr. Dargo, telepsychiatry, telemedicine. Holly Vance, nurse practitioner for internal medicine for courtesy privileges. Christine Weissy, family practice, courtesy privileges. Dr. Williams, OBGYN, moving from provisional to active staff. And Dr. Zuleta, family practice for courtesy privileges.
Move approval of advancements.
Second.
Moved in second, any discussion? All in favor?
Aye.
So moved.
Thank you. I've got 2 reappointments. Dr. Plastino, emergency medicine as active staff, and Dr. Richard Demler, family practice as active staff.
Move approval of reappointments.
Second.
Moved in second, any discussion? All in favor?
Aye.
And then the one final thing, which actually you need to motion and vote on is so there's just a typo on the list there. Addition of special privileges for Kayla Gomez, PA in family practice. She requested the addition of first assist privileges to her set. And she also has experience as working as a first assist and has volunteered to do that to help out doing call for first assisting for the OBGYN department.
Move approval of addition of special privileges.
Does that need to be, it says informational only?
That is a typo, Dr. Kammermeyer. You actually, to add a special privilege, it should be motioned and voted on.
Thank you. Second.
Moved in second, any discussion? All in favor?
Aye.
So moved.
Thank you, everybody. There was no other report for the medical staff from Dr. Lemmy.
Thank you for filling in.
Thanks.
Moving on to health tech report, we have Faith Jones.
Hi, so thank you for having me. I am Faith Jones and I'm the Director of Care Coordination and Lead Consulting with Health Tech. So I have had the opportunity to be here all week. So I've been here working with the clinics, working and looking at the care coordination programs. So you currently have some care coordination that's happening through ChartSpan. We went through, reviewed what that looks like, and I'll be kind of putting all that together in a report and getting that to Dr. Miller and to Mike. And also looked at some of the systems that you have around some of the care coordination pieces and looking into doing care coordination in a couple of your other specialty areas. In particular, focusing a bit on oncology, because oncology is an area where patients really do appreciate that hand holding and all of the stuff that happens with them, where they've got to transfer care and move around and get tests. And, you know, it really does take some coordination. You have a program now or a person now, a nurse by the name of Lena, who's doing this work with some of the survivorship patients. And they really value that work that's happening. So being able to elevate this program into a true principal care management program does 2 things. One, it becomes something that a patient can stay with and we can track it and trend it. And it is also a reimbursable program under Medicare. So looking at those areas, and the other one, looking at also in our oncology, but is the palliative care program. And having the palliative care program have a little bit more structure around it. And they're doing amazing work in these departments and we want to give them credit for it. So they get credit for it and then brings revenue in so that we can continue to make sure we have the staff we need to continue these programs into the future. We're also looking a bit at what it would look like in orthopedics to do something around some of the total joints and really following these total joint patients. It takes 2 to 3 months to prep a total joint patient, all the way up to a full year until they're fully recovered. And there's a lot of that behind the scenes work, and that's what care coordination really does. Put some structure around that behind the scenes work. So we're looking at all of those things. It's been fun and lots of great people that I've had a chance to talk to. So that's what I've been up to, and I will likely be back again as we kind of move forward. I know you all have a report of some of the other things that have been going on. There's lots of health tech interaction with many of the departments on a regular basis. Some of them are weekly, some of them are more often than that on phones and video calls, those types of things, as well as there's been a few additional site visits that have been here. Carolyn St. Charles has been working, I know, with your quality and with Shannon, and then also Sherry Benander, who's our consultant for compliance, has also been working with Shannon. We're also looking at future consulting. We'll be kind of doing some more of a follow-up. Lena Verlene Luna, I should say, has been here already at least once and kind of doing some follow-up around the rural health clinics. And then, of course, looking at some strategic planning initiatives as we move forward. And want to make sure everybody's aware of the education that's happening in September out in Monterey. Any questions or anything that I can answer or I can try to answer for you?
I'm not sure that we've had sort of a tutorial or that I've had one registered in terms of the care coordination program. On how someone would be invited to be part of the program or how that takes place and then what actually happens in that. I don't know if this is a time to get that tutorial or perhaps at a subsequent meeting.
Sure, I can give you a high overview of it. Care coordination is something that went into effect for rural health clinics in 2016. And it is something that Medicare understands. It started as a Medicare only program. There are a few other insurances who do cover this particular service, but mostly it's focused at Medicare. And what Medicare wants to do is they want to make sure that particularly primary care practices, and that's where it got started. So in your clinics in Oak Harbor and Clinton and Freeland, making sure that in between visits, and when things, not just the regular visits, that doesn't change. You go in, you see your doctor just like normal. But in between that follow-up, that follow-through, that, gee, I have a question. Should I go in? Shouldn't I go in? What should I do? You have that single point of contact, which is the care coordinator that you can call, you can ask questions of. They can help you kind of maneuver the system. The healthcare system is complicated. It's an incredibly complicated system, and we can't make it more complicated every day. So having someone that can help you kind of maneuver the system and making the right decisions for what you need for your care, getting reports, finding if you went off island, for example, and saw people in other places, getting some of that information back so that we have a really great complete picture of what's happening with the patient. So that is a billable service under Medicare Part B now. And which means it is, there could be a copay, so we do have to make sure patients understand that. And but if they have a supplemental insurance, the supplemental will cover the copay because it is a Medicare approved service. Or if they are dual eligible, meaning they also have Medicaid, Medicaid covers the rest of that as well.
And how are they brought into this?
They must have 2 or more chronic conditions. So the best way that we recruit people is one, scrubbing their charts, finding out who all qualifies, and having conversations with the patient, telling them about the program, letting them know they qualify. And what we're looking, they have that, like I said, that single that can go through the charts, work with them, call them, remind them of things, see how things are going, find out if they have questions, help them with medication refills, those kinds of things.
And is that somebody that is employed here by us?
Well, for the PCM, so Principal Care Management is that exact same program, but it is for specialty practices. And we are looking at those because specialties are so, they're special, right? You want to make sure you know what's going on. So in oncology in particular, we are looking at 2 RNs who already work here and already do a lot of this work. So just giving them the tools to be able to capture that work, to plan that work. And that, I don't know, Luna is an RN in oncology and Diane is an RN who works with palliative care. So those are the two areas in orthopedics. Natasha is an RN who already works here, yes, and she works over in ortho. So we're looking at giving them the tools they need to be able to collaborate and track and make sure that things don't fall through the cracks as we're trying to get people between different specialists, and that the specialists are communicating back with primary care, because that's always an important piece too.
Would they also be someone that would help if somebody is having cognitive deficits and unable to process things and really needs to have like a guardian ad litem or something, or is this in lieu of?
If somebody got to that point, they would help make sure that that happened. No, they are not their personal nurse, so they wouldn't be able to do those kinds of things, but they do have great connections with community resources. And being able to connect them with community resources, helping with rides, because you have lots of opportunities for different people who give transportation. I can't get to my doctor's appointment, what do I do with that? Those kinds of things that they would help coordinate all of those pieces with patients.
And who refers the patient to
The
this?
provider.
The provider does. It's not self-referral.
It could be if the provider's okay, like usually it's pretty low, so if I wanted to be part of it, I have to see the provider who this care coordinator is working for though. So you're welcome.
Question. So you use phone solicitors to recruit these people, correct?
So we don't do that in our principal care management program. The current program that you have right now that we're working through, the chart span that has already been there, they have done some stuff through the telephone. I don't know, Dr. Miller, do you want to talk more about that?
And let me go on.
We employ a company to make phone calls. And we'll roll.
So basically, there's been a few complaints regarding the high pressure sales from these phone solicitations. Can you explain what's going to change about that?
So I don't actually work for or represent ChartSpan. ChartSpan is a form that we don't necessarily use in many of our other hospitals or clinics. We like to make sure that it's done in-house, particularly in rural areas, because we all know rural has unique needs. So it'll all depend on what's going to happen long-term with the ChartSpan contract and where that's going to go.
So you're endeavoring to replace ChartSpan.
At least when the contract ends, if not sooner.
Okay.
But the ones that we do in principal care management, those are different programs, same concept, but those are not covered by ChartSpan. ChartSpan is not involved in anything along those lines, because those are specialty ones, and that's the principal care management. So those are the ones we're going to probably start with and focus on.
Okay, and the financial cost and split between the solicitor and the hospital.
So there isn't actually such a thing for principal care management. There is a software that's a relatively low cost to track things, but it's all done in-house, and all of the training and education you get from me. And because you're a health tech company, you don't pay for me, other than me coming here. But
Basically, in the past, it was an $80 fee, which was split 50-50 with the hospital.
so
You're saying that that is not going to be the case anymore.
that's not the case with principal care management or anything that I do. ChartSpan, that is a contract you have with them. So when that contract is either up or you get out of that contract, I don't believe that's going to change until you deal with that contracting piece.
So it is a possibility. Yes.
Okay, thank you.
You're welcome.
Any other questions?
I want to thank her for coming. She's really been a great help. She's educated us, and she said she may be back. No, she will be back. So we will be having her come back. And she can do some virtual work for us and in-person work. I think she'll be a great help in our clinics. the CCDL and bringing in the physical care management program. So thank you very much. You've done a great job.
Thank you. And we've kind of planted some of the seeds for behavioral health as well, because we do behavioral health integration, behavioral health care coordination, and I know that's on the horizon.
Yeah, she's a national speaker too, and she does have a lot of expertise in certain areas like behavioral health, CCD, physical care management. So she was going to be a great help to us.
Can you expand on your behavioral health situation a little bit,
It's the
please?
same concept as we were talking about with chronic care management or principal care management. Behavioral health care coordination is for patients who have one or more mental health diagnoses. And again, it's all that behind the scenes work outside of an appointment that a care coordinator, and again, this would be someone who would need to be local part of your clinic that could reach out to patients, check in on them, making sure they had rides. That is a population that needs a lot of help and tend to have high, for example, no-shows. And part of it isn't because they don't care, it's because they just don't have what it takes to be able to on a particular day, maybe get to an appointment. So that extra hand holding, that extra phone call, that do you need a ride? Can I help you get this set up? Really helps them to keep their appointments, which then helps them to get the treatment they need. And so it really is kind of that cycle. And so care coordination for behavioral health is all in this same bucket and is still paid at that same $79.25 per patient per month from Medicare. Unfortunately, Washington Medicaid is not covering it yet, but that is something that we are tracking. But for your Medicare population, it's a huge help.
Very good, very good. Thank you very much.
You're welcome.
And you're welcome to stay here and attend our entire meeting. I know you've got a lot of kids.
Yeah. Thanks.
Moving on to quality report, Dr. Miller, you're gonna get quality report and then the operations and outpatients.
Actually, Shannon, I'm going to present the quality report today.
Oh,
The next slide. Welcome, everyone. So for quality management system, policy medical, we have 730 overdue policies out of a total of 1908. We've had 127 policies updated since the last board meeting. And policies not updated by December will be archived, so the teams are working through all of their policies currently. For medication safety, we have 3 medication events in May related to missed dose, dose incorrect, and medication process issue. No patient harm. For fall, we had 1 fall in June, which resulted in temporary harm as follow-up intervention was required. For workplace violence incidents, 7 events in June, and 2 of the events resulted in staff injuries. Out of those events, there were 4 verbal, 2 verbal physical, and 1 physical. And the locations are listed below. It's imperative that we're doing those debriefs in real time to support our staff and ensure safety for all. We've had 38 workplace violence events year to date, and we're still partnering with WISHA for workplace violence de-escalation training for our staff. For restraints, our objective is at 90% for June restraint documentation compliance. It does continue to decrease. Training has been provided. The electronic health record has been updated, and we're recommending real-time auditing and reaching out for assistance in those live events so we can support. Our infection preventionists went to the APIC conference, and with increasing challenges associated with the pandemic, leaders need to remain positive and authentic with their teams. So Whidbey Health is on track with the recommendations provided during the conference related to infection prevention for our entire organization. For HEDIS, our continued focus on care gap closures for Whidbey Health, patients and quality incentives, continued focus with our payers on care gap closures. For accreditation, we did have a successful Commission on Cancer survey. We had a successful CAP lab survey, and Health Tech has completed multiple mock surveys for Whidbey Health, and all action plans have been assigned with leaders with tentative due dates in September, and our DNV survey does open September 1st of this year. For our event reporting and risk mitigation, our events for reported illnesses have increased, employee illnesses, and diagnostic imaging events, and also surgical services divert due to insufficient staff and providers. Risk to the organization, we have spoken about this prior, critical staffing due to employee illnesses and just staffing overall. Our multiple electronic health record systems not integrated, resulting in 2 patient portals. And our continued focus on just culture, and also our current focus on organizational culture, really focusing on communication, addressing all of our customers with staff training. Our education department is working on clinical orientation, standardizing onboarding competencies, working on health stream, making sure they're the right modules in there, not duplicates, and standardization of education processes overall for the entire organization. Our medical staff office has 11 reappointments, 7 initial appointments, and we now have a total of 260 total credentialed providers. And you can see the August initial general surgery, neonatal, OBGYN, and multiple telehospitalists. For Survey Vitals, our patient experience platform, our emergency medicine for June 2022 increased 5.3 regarding wait times and overall were the lowest scoring components. This is not unexpected as current census and bed availability. Our walk-in clinic did see a decrease of 0.1. Clinton holds higher score for all components for wait times. Over 60% of survey responses indicate that a patient would recommend the facility to family and friends, 10 out of 10 times. Our outpatient care did see a decrease of 0.01. Wait times remain the highest scoring area for the organization, followed by provider and staff, and reception and scheduling are the lowest scoring at this time. We're continuing to move to Qualtrics as our patient experience platform, and so Survey Vitals will be sunsetting at the end of this month. So for HCAHPS for March 2022, communication with nurses and doctors, communication about medicine and discharge information, staff responsiveness, care transition, and quietness all surpassed the national average. Hospital room, restroom cleanliness was below national average. And percentage we definitely recommend the hospital was below national average. 38% definitely said yes, and the national average would be 71%. 8% said probably, no, definitely no. And percentage you would give the hospital high rating was below national average. So these are all of our inpatient surveys for March 2022. So at the last board meeting, we pointed out positive patient feedback for Whidbey Health. And this meeting, we are focused on opportunities for Whidbey Health per commissioner's request. So we are going to, the slides are attached. We are actually going to look at a couple of them today. So the first slide we're going to look at was feedback from a patient that stated, needs better communication with what is happening to surgery timing. Waited for about an hour and a half. No one checked in on me. Staff was surprised by my significant other in the waiting room. They didn't have their phone numbers, so we wondered why they didn't call them. Could have been in sooner. And so the next slide I would like to look at is Clinton Primary Care. And the points were stronger communication around prescription plan and staff answering the phone. I would like to get someone by phone to change or make appointments and also to call in the medication refills. Need more people to answer the phone, more doctors. It's too hard to make an appointment. And then the other slide that we want to look at is medical ambulatory care. The overall time was never given, just the procedure time. It was more than twice as long as I expected. Follow through with patients and referring providers in a timely fashion is lacking. And then the last slide would be women's care. more communication from the physicians at the clinic. I felt left in the dark about my provider and who I would see now. So I think it speaks volumes about communication where we are as Woodby Health Organization, and that perception is as important as the experience in our care. So please read through those slides. If you have any questions or feedback, please let me know. And we are diligently working on feedback across the organization, which Tim will address too with the culture.
Think you any questions? Good report. Yeah, it is when you in the past, actually don't get the negative ones. And like I said, we've always talked about you can't fix the problem unless you know the problem.
Correct.
So I know that a lot of things are going right, and it's kind of hard sometimes to put the negative things out there, but we really appreciate that. Like I said, keep the board informed, doesn't mean that anything bad, just that way we be responsible. Thank you.
The question. The report on cleanliness was poor. What have we done to try and correct that? And is that under Tim's
It
jurisdiction?
is, we're extremely short on staff, we're doing everything we can to, we actually, there was an interview today, we're trying to build up that team. We have about 5 open positions, we're offering, sign-on bonus for those positions. I had our supervisor go to the job fair that was earlier this week with Loretta and HR. We're doing everything we can to recruit. We're trying to get it out there on our, marketing. We're bringing different positions to the forefront as much as we can. We are looking at possibly bringing in a contract. We have all of our clinics are contracted out. We're looking at possibly using some of those resources to see if we can get some of our non-patient care areas supported through some of the contract teams. So we're doing everything we can, but like everybody else, we need staffing. It's a lot of square footage to clean. Overall, our cleanliness, when we do infection checks, Pauline Clam goes around and actually does checks, actually come back very, very positive. So the building is clean, but it is, at the end of the day, it is a matter of perception. But we are doing everything we can to build that team back up, just like all the other departments.
Good, very good, thank you.
And James and Mike will be volunteering for you.
We greatly appreciate
it. They were gonna set an example of rounding, they'll be cleaning. Thank you. Be careful.
Yes,
Well,
yes.
speaking to that, we all own a piece of cleanliness for the facility, so it's all of us assisting where we can help too when they're short.
Back to Dr. Miller.
Thank you. First, a behavioral health program update. We successfully completed and submitted a grant for a HRSA grant, Health Resources and Services Administration, as part of the federal government. It's a $3 million grant, $1 million a year for 3 years. We should hear next month whether we receive it or not. That having been said, we are still going to proceed whether or not we get the grant or not. It's just that it might progress a little more slowly if we don't have those funds. We've been in contact with various local health officials on the island, getting their input as to what the needs are in the community. We've got a bunch of people involved and gave us a lot of support for this program. The plan is to reopen the Freeland Clinic with a combined behavioral health and primary care clinic. We're actively recruiting providers for that clinic, and we've started a project management team to work on reopening that clinic. We're targeting November 1st. I'm not sure we'll be able to meet that goal. The biggest issue we have is staffing, which is already a problem with all of our other clinics, but we will see what we can do. On the recruiting front, we are actively recruiting and interviewing candidates for the psychiatric mental health nurse practitioner position, the clinical psychologist position, primary care providers to work in these clinics, to work in Freeland, but also primary care providers to work in Oak Harbor, Clinton, walk-in clinics. We're also opening up recruitment for a general surgeon. We have 1.5 general surgeons right now, with at least 2.5 to be fully staffed. And we're also starting to look for another orthopedic surgeon. We know Dr. Addition wants to retire at some point in the next few years. We want to get ahead of that and try to find someone to take his place one day. Moving on, other highlights on the pharmacy side. We administered our first monkeypox vaccine in retail pharmacy yesterday. We are now set up to do that at the request of Island County Public Health. And so that resource is now available to our community. We sent out information to all our medical staff. Folks that get that vaccine have to be screened by the Island County Health Department first to make sure that they're appropriate candidates. And then they'll come to our retail pharmacy and as a scheduled appointment to get that vaccination, to hopefully reduce their risk of getting this disease. The program for our retail pharmacy to provide the medications for our hospice patients is going to be piloted starting next week. We hope that that will be a good service for our hospice patients, as well as a boon to our retail pharmacy. And then finally, the Meds to Beds program that we've talked about for some time and is a best practice. We're working to start piloting that also in the very near future, hopefully this next week. And then finally, Freesia, which is our intake solution that has actually worked really well in our primary care clinics. That's what patients get alerted via text of their upcoming appointment and can pre-register and forms and pay their copay all from the convenience of their home before they arrive. Or if they don't do it ahead of time, they can do it in the waiting room with a pad, a Freesia pad. That's gone very well in the primary care clinics. And we are rolling it out to the entire organization this fall. And we're starting the operations and technical aspect of that this next week to get that going. That concludes my report.
Question.
Yes.
Freeland Clinic, we had a limited time under that license for us to open. Are we going to make that deadline?
So the deadline is a moving target right now. One of the targets is the date at which the public health emergency ends for COVID, and that keeps getting pushed back. It's currently mid-October. However, if we can show to CMS and the DOH that we have a plan to reopen the clinic, the information that I've received is that they're likely to approve it. The other deadline is 12 months. If we go an entire year without reopening clinics, I've been told that it'll be very hard to get CMS and the DOH to approve its reopening. So that's next April. So we have next April will be a year.
We will work hard to get an extension if we have to, with a plan, as you mentioned, we can. And we're also currently working on a pro forma right now to open it up, so we can show the pro forma revenues and expenses, staff and equipment. So we're pretty convinced if we have to, we can get an extension.
Yeah, if we just can open it with one provider, that would be sufficient. So I think we will be successful in reopening it.
Yes.
At least to some degree. I don't think we're going to lose the license. We will be able to keep it.
We'll even have a plan B if something really happens. We'll still get these providers we're recruiting, you mentioned, and the behavioral health program moved to another spot. Again.
So with the lack of support personnel, I guess the intention is if we don't have the support personnel, we'll put the providers in either the Oak Harbor Clinic or the Clinton Clinic. So can we move one provider out there all by themselves with no support staff to open that?
That would be very difficult. That would be very difficult, but if we will figure something out, if we will not lose that license.
I get it. No.
We'll figure it out. Even if we have to move one provider and one support person, to Freeland.
Would that be like a very experienced nurse?
It could be.
Yes,
I could volunteer to give you
Okay,
yes,
that would work.
we're gonna work the yes here in just a minute.
Do we need a vote on that?
I'd do that. I'd be the support person
Okay. Okay.
temporarily.
Do you still have a nursing license?
I do.
Excellent, there you go.
3-year no
Problem
outs.
solved.
3-year no out.
I'm sorry.
3-year contract, no outs.
Thank you, Dr. Miller.
I think you can understand the importance it is about opening that clinic. There's a lot at stake there.
Moving on to our finances. Kelly.
Yes, so I'm very pleased to report. I think it's good to look back and see how far we've come in a relatively short period of time. So I want to just take a quick walk through from December to where we are at the end of July of this year. So in those 7 months period of time, the organization's experienced a lot of ups and downs and major challenges. Again, I use this analogy at the last working session, since we are in baseball season, using that analogy from the financial health of the organization, we've made it to first base. And now we're initiating a whole bunch of projects, both revenue enhancement and operating cost optimization to try to get us to second base. So let me get into some more details here. On the challenge side, I hear, because I'm the newest kid on the block here, that it's pretty normal either in July or August, or sometimes both, to experience lower patient volumes just because people travel on vacation and a few other things. However, what we've already are well aware of, we've got challenges on recruiting providers. And if you don't have providers, very hard to grow the patient volume. So patient volume is a huge focus throughout the organization, and it's being helped by the recruiting efforts of several people in this room. That's just for emphasis, putting that out front. That's our biggest challenge, is getting our patient volumes up. And then on the successes, as we've said in previous meetings, we were successful in the middle of July refinancing a new bond, 3 new bonds that went out totaling $15 million, which, again, keeping in mind it's borrowed money. Out of that transaction, we paid off $6.8 million of short-term debt. And so then again, connecting it back to where we were on the balance sheet at the end of December off the audit, we only have $4 million of working capital, which is defined by current assets subtracting your current liabilities. At the end of July, we improved that number by $16 million. So we're up to $20 million in working capital. And that allows us to be in more of a strategic mindset so that we're not in a reactive crisis mode. And so that's why, again, part of this is a repeat of earlier, but I want you to just to recognize as a board that we can, as an organization, make well-informed strategic decisions and focus on things that will really add value to the long-term sustainability, which all adds up to the financial health of the organization. So in the last couple of months, we have at the operating loss level, we have lost money before depreciation. If you add the depreciation back in, we're positive. So the metric that's used commonly in the industry for nonprofit and district hospitals is earnings for interest, depreciation, and amortization. So they have been trending downward, but they're still positive. So for example, July year to date, that metric is 2.6 million positive, but based on the year end, which was audited, it was 4.8 million. So that's again comparing 7 months against 12. So we're not doing all that bad compared to last year, but we've got really, I think, based on the talent that's in this organization and the potential that's in the market, based on what I've been informed, you know, our opportunity to grow our market share is pretty good if we can approach it correctly, and it won't happen overnight. But anyway, that's kind of a high level take. We've got several different initiatives we're working on on the finance side. We're rebuilding our accounting staff. We have 2 people out on COVID right now, and anyway, like a lot of the other departments in the hospital, we're aware of that. We're just coming up with resourceful, creative solutions. Anyway, that's my report. You guys have any questions?
Cash on hand. Days,
Yeah, thanks.
days, cash on hand.
Yeah, so as of the 15th of August, we had on the operating side, 26 days of operating cash. Then we add to that our safety net, which is this last refinancing. That's borrowed money stuck in my back pocket or the organization's back pocket, 22 days. And then we have an additional 5 days as a debt service reserve. So if you add up those 3 numbers, it's 53 days altogether. That was as of August 15th.
Okay, can you compare that? I mean, with all of the various things to, say, December, when we were first talking about. My recollection is that we were somewhere around 3 days.
Yeah, technically on the balance sheet that got audited, the days of cash on hand was closer to 18 days, but then it went down to 3, like in February before I got here. And somebody told me on certain days it was in the negative. So yeah, and that ties back to my opening comment. If you look how far we've come financially in a relatively short period of time, it is remarkable, and it's a reflection of everybody in this board meeting, including the board members and all of the executives and their teams. It's been a heavy lift, but anyway, I'm very optimistic on our ability to get through these improvement initiatives over the next several months, because they will have a financial impact in a positive direction.
And I do think it's important when you're giving that sort of an overview that we remember where we started in terms of language and numbers that some of us who are pretty simplistic can understand. Going from 3 to 53, even if to stop at 26, that's pretty significant in anybody's book.
It is, yes.
Yeah, and I think the 26 is really the number we need to be working.
Yeah.
Rest of that is basically a reserve and
Yeah.
borrowed money. So,
Yeah.
Yeah, and so when we, just to illustrate that point, that is what Nancy is saying, that's what we do on our daily executive huddle. We start with that top number, and because ideally over time, like some of our board members have specifically agreed with me that we're all debt adverse. Over time, best practice is let's generate cash flow out of operations and pay down the debt over time. But as a safety net, it's good to have that excess cash in the reserve in case there's some external factors that we don't have any control over that hit us, and we need a little time to react.
Tim would take the money to hold the facility together.
Okay. On the loan that we have, we're paying 4-point-something% interest, correct?
Which loan? are you-
The one we just took out from the bank, $10 million.
$10 million. Yeah, the blended rate is just right around 5%.
And that money is deposited into Heritage Bank, which is paying us practically nothing in return. Have you contacted Heritage Bank or looked at the possibility of moving that money to a different bank?
I haven't had that conversation with them yet, but it's on the to-do list.
If I might ask the chairman, you have a relationship with Save On Bank. Are they paying 0% return when you have somebody that deposits $7 million in there?
It's Savvy Bank. And
Savvy.
I really can't make a comment because it's a definite conflict of interest.
Right. But I think it's obvious that Heritage Bank is taking advantage of our situation. And I would not be opposed to moving that to a different bank if they do not pay us a better rate of interest.
I'll report back at the next board meeting what we do on that.
Thank you.
Is there anything else? Any other question? Okay, we go into IT. I take it, Tim, that you're gonna do IT and facilities both?
Yes.
Okay.
Thank you. So with IT, happy to say that the board had approved, us to move forward with purchasing the, virtual infrastructure and storage capacity expansion. That was expected to arrive in December. It actually arrived last week, so we're starting to put that together. So we're gonna get a little bit ahead of schedule, which is good because we will avoid any failures hopefully, and buying more refurbished equipment to keep it up and running. We are ahead of schedule with single sign-on. John and IT has done a good job of building the virtual servers for that and getting that prepared so that we can continue moving down the road, hopefully before the end of the year, having single sign-on in place, which will make a lot of people, clinical people, providers happy, and helps with some efficiencies.
Can you clarify that for me a little bit? A single signer, what does that look like? Or maybe,
So it's basically, to simplify it, it's a badge reader. Our badges will work with it. You present your badge. There's a lot of work that has to go on behind the scenes. You'll just basically single sign on rather than logging into each application. Depending on your credentials, it'll let you get into Meditech and all, EMRs and applications that we need to with just one sign on.
great.
So it'll make things a lot more efficient. We are also working on a plan. There is a lot of old computers out there that are just slow. That we're working on that plan to get that going again to start replacing some of that equipment behind the scenes that will also help with the speed and efficiency of getting onto the computers. There was an outage with Athena this morning. It did get back up around 11. Comcast actually had a fiber that was pinched. So they did get that located and back up and running. We were very close to having to shut down cabin for this afternoon because they were just getting really behind. They would have had about 4 or 5 hours, or they still do. But they have about 4 hours to make up getting all the data put in now that the system's backed up. So that's good because we didn't have to close the clinic. Then as far as facilities, we are very close to completing the boiler chiller project. We had some work done last weekend to correct some equipment that controls the temperature on our surgery suite and throughout the building. So that was completed. Now we're just working through the punch list. The seclusion room, we've got the final approval from the fire marshal. We had to reorder some things to cover smoke heads and make that room meet the fire marshal's requirements. So hopefully, once that stuff's here, hopefully by the end of the month, we can move forward with getting that room through DOH occupancy approval and getting that room open to help out some of the capacity issues we've been having in the emergency room. There is a lot of work right now being done, obviously, with the mock survey and getting ready for the DMV survey as far as facilities go. So there's a lot of work going on to complete those items and get us ready for DMV. So facilities is extremely busy with that type of stuff. We, as Shannon alluded to, and kind of all the negative out there, because there is negative. There's a lot of positives, but there is negative. We have formed, as I've reported before, an organizational culture committee. And we had a task force meeting yesterday we got done a little early, but it was about 2 to 4:30. Putting together the agenda to start teaching the leaders of the organization on AIDIT, the expectations, giving them the tools. And talking about things that we're going to expect and hold them accountable to. And then they will take that and start training the staff on, AIDA customer service, building up our culture, how we expect everybody to interact with not only each other, but our customers, our patients that are coming into the organization. I love Curtis and Shannon, they're part of that, if they want to talk about that task force, but I think we have a really good plan in place. We're going to be putting together a video, demonstrating what people role playing, how it looks bad, how not to do it, and then how to do it correctly. We're going to have rounding sheets, make sure that everybody is being rounded on a regular basis so that we have communication, that we're listening to our teams, gathering information, making sure they have the tools to do their job, and making that personal connection. Sometimes that is forgotten about. Just making sure they're okay, that we're here to support them, that we care about their needs, and we're here to listen and take care of them. Because they're as important as, as the patients. So a lot of work being done there.
A lot of this is based on this student concept.
Correct, yeah.
And it all starts with leadership and teamwork, and so that's where it all starts in the role. Thank you for all the good work.
And then additionally, just this is the board's aware, AHU4, which is an air handler that serves the basement area with high quality and net records, is we have to replace that. The initial price was about $852,000. We're working it down. It's about $829,000 now. I am still waiting on another quote. We're hoping to just do a change order on the boiler chiller project so that we can do it through the energy savings program that we did the boiler chiller project with. The lease agreement that we're also in progress with for the antenna roof lease, which is $800,000 that will be coming in, will be used to hopefully cover this expense. But it is something we have to do because the unit is it's a 1989 unit. It's old. It's done. It's served its purpose. So. And then also, I just want to make the board aware that next Wednesday on the 24th, we will be having an employee picnic. So administration will be grilling, leaders will be doing serving out in the courtyard by the cafe from 11:30 to 2. Hot dogs, hamburgers, veggie dogs, and veggie burgers, and lots of sides. So if you get the opportunity, please stop by. That's my report. If you have any questions, I'm glad to answer.
I don't understand all the ins and outs of the USDA loan. But would that be something that could pay for this chiller that has gone out on us? If we paid first, could we then submit to USDA to reimburse us?
No. And we've been, I've had David Johnson with JJC out here twice now. He's reviewed the whole process with Mike, and then also we just reviewed it with Kelly. That money is allocated for infrastructure, mainly on the electrical side, because we have a lot of electrical. Some of the things that we corrected when I first got here, we had things that were on the wrong transfer switches. You have transfer switches that are for life safety things. You have transfer switches that are for just general use. You have transfer switches that are for equipment. Things were on the wrong transfer switches. So we had to get all that straightened out, which we did. But we still have a lot of other electrical issues that we have to, a portion of that money has to be for that. The other portion is for refinancing a number of our debts to get them at a lower interest rate. And then the money, roughly 22 million that was left over, is for whatever we originally were looking at doing oncology build out, redoing the lobby. But we're starting to have some discussions. Kelly and I actually have a meeting tomorrow to kind of fine tune that a little bit, because we will have to resubmit a PAR to USDA. We had to do that when we kind of changed plans, when we found out we couldn't do it and use it for the emergency room. But now that we're maybe going to change that scope a little bit, we're going to have to resubmit that, so that could take 3 to 4 months. And then once we have the finances, to help support that, then we will move forward with that, but we can't use it for an area. I would like to, but unfortunately, we can't.
I didn't know, but I just, thank you.
Any other questions for Tim? No? Moving on to Curtis.
I'm gonna try and keep it short. I know time is of the essence for us all. The biggest thing I wanted to talk about is our upcoming conversion to telehealth at night, starting September 1st. We've started our initial training and it included the house supervisors and charge nurses. The reason I wanted them to go through it first was for the admission process through the ED. I have concerns that when patients come to the floor and then do that afterwards, we've had problems with that in the past. So the house supervisors and the charge nurses will be responsible for working with telehealth on admissions. Going through the process itself, it's going to be pretty neat. I do not expect much pushback. I think once we have the initial training, which is tomorrow for the general staff, they're going to realize it's a pretty neat system. The longest it would take for any response is 60 minutes, which is really neat because it could be just identifying a trend. Hey, I've noticed potassium's not quite critical yet, but we're trending downward. We want to get ahead of us. We'll get those kind of responses within 60 minutes. They have a really good response time if it's an emergency. And it also is really neat because it's driven at the nurse's station, so they're not having to worry and go find that tower that's the machine. They can do it at their own. We've already worked out some of the workflow on that. If it does require a call back, it'll go to the hub, just like we used to our health unit coordinator, who then immediately contact the nurse. So it's not ringing to phones because nurses aren't at, we don't have a centralized nursing station, so there are people sitting at the phones on the floor. And I want to be respectful of the doctor's times. So that's exciting. We're going through that. We're going through reviews. Everyone's working on their policies and initiatives to be ready for DMV. I'm confident we'll do well. We did have some survey on charts and stuff like that, and it went fairly well. The health tech reported she didn't think we'd have any problems with our audit. So that's a good thing. And the other thing we both talked about staffing needs, and we're going to go on and out. But when you talk about changing your culture, it takes everyone to recognize everybody. And so with that, I would like to challenge everyone who could go around and call them the groups. I've had a couple of cases where people don't know who all the executives are. And I think that's important that they know. That was a doctor as well. So I still would be challenged to go around and look at everybody. Because that's important. When you look at change of culture, it is like you said, it's going to start from the top. And if we're not walking around and talking to people, it's going to be nothing better. And Tim and I had a really good meeting yesterday. It was interesting because it was open, it was comfortable. And several of the participants talked about the concern of, well, we've done this in the past, and this is just another idea, and it flashed in again. We assured them that this is not, this is for good. This is part of our strategic plan to take this hospital to a different level. And the excitement when people started realizing, okay, this isn't just another exercise in fertility. This really is an absolute. There's a lot of excitement and participation. And I think the fact that we're bringing in the funding people to help create this program, the sense of ownership is good. So that shared governance has been very good for this program. And a lot of them are coming through. And I think the teams that we have now are really, as Shanna shared in their nursing metrics and everything about the national average. Despite the challenges, we continue to do that. Everyone does. And I keep telling everyone 2023 is going to be the year. I think we're finally in 2022 this year. So, as Mike would say, kudos, but it's kudos. Anyways. Kudos to everybody, from leadership, to the board, to our managers, to every single person who walks through the doors and works with us. Is making a difference, and it's exciting to see those changes happen. If anyone is a nurse and wants to work for us, or a housekeeper who wants to work for us, or kitchen, please let us know. That's another step that we need to fill to continue our initiative and build rapport and culture. Let's get some extra staff before we get tired.
Both the, you were looking for an RN, so.
What's that?
Y'all can compete for Greta, the two of you.
I'm only working 6 to 7 days a week, so I need some help. Well, a veterinarian. Oh, compliance, come on. Yes,
Thank you.
but James, that's our.
Can you give us a update on the swing bed operation?
Main bed operation, the program itself is working very well. So again, it comes down to staffing. I mean, we have staff. We're getting people calling and wanting to transfer the one swing bed we have now. Came from Skagit. We had another call just yesterday from Swedish. It's just a matter of having members and staff to accommodate those needs. So the program is working great. It's just, again, it's a matter of getting staff. It's allowing when your top hospital in Washington State goes on the list. That gives you an idea where those of us clinicians, our ears are perking up and going, okay, this is not good. And our trauma one was low is under. Yeah, we do have a concern. It's we're all fighting for the same amount of nurses, and a lot of them are retired from pandemic care. A lot of people have left the field. And we had a shortage to begin before we hit the pandemic. We knew this was coming, but it's going to be quite significant in the years to come. We're going to have over 1 million nurses shortage in the United States for the next couple of years.
Thank you.
Any other questions? Moving on. HR.
Okay, now, Loretta, had a couple of priority interviews, so she gives her regret for not being here. So she tasked me with giving her a report, which I bumbled the last meeting, and I'm gonna try to make it right this time. She's got it detailed for me, so I'm gonna read a little bit of her report. Our team was able to recruit in 14 new hires this past month since we last talked. Throughout various areas: diagnostic imaging, patient access, rehab, information technology, intensive care, family birthplace, surgical services, primary care, up in the Cabot and pharmacy. So we're beginning to attract, even though there's a big staffing shortage. Oh, there it is, big staffing shortage going on. And we also have some students in here, which is very nice, and some contracted staff, which we regret having to do that, but you have to, we're having to go out to bring in contracted members right now, travelers to keep up. And then in departures, I think you can up there and see that we had 10 employees leave. 14 recruited in. So year-to-date departures 123. That is a very high turnover rate, but you can see that year-to-date it's been 15. It's been higher than that in the 20s. Our goal is 10% of this. In this market, typically it should be 2 to 4%. But we're in the most competitive market I've ever experienced in my entire career. This competitive market we're in. Next. We are rebuilding the HR staff. We've got down to 1.5. Our staff is half total 4. So we're very fortunate to find some good folks there. Next slide. Loretta has brought in a lot of new strategic processes and workflows that can make things go easier, so she's working on that. Great job, for us. Thank you for Loretta's report. Hopefully, Loretta will compliment me on this, but I don't know. We're giving her a report, so thank y'all for bearing with me on that.
We'll move right into administrative report.
Okay, first compliments to everyone, the support staff here that are taking care. This is everything is accomplished through teamwork. And we've got a great team going on here. They pretty much hit on most of the things that we're working on right now. We do have DMV coming in. Just want to emphasize that again. Shannon mentioned they should be here in September. We had a great finance committee meeting, I think, yesterday. Some of the highlights in it, to me, is that we are, and Kelly may have already mentioned this, I had to step out for kind of an emergency call just then with Mr. Golden. We are beginning today the creation of a new budget for next year. We are completing our capital equipment list to get that budget going. We will provide you with a cash flow statement at our next meeting. Working on the interim cost report, I think you mentioned that. And we'll tweak the strategic plan coordination that we'll have a balance sheet and income statement we can show to you at our next meeting. So those are some really positive things. Kelly has completed his reorg of the finance department, which was I think we had 3 people and I think we're back to 9 or so. So we'll be able to give you a lot better information. So we're proud of those efforts. I'll just cut to the chase here and end by just saying we're in the midst of a turnaround. We have unprecedented challenge facing all hospitals, in particular our hospital, and you've heard it that staffing shortages is unprecedented out there, recruitment, and we beat that in the head, and I think we've said enough about that. We will continue to recruit. Diversion is causing us still issues. We have a lot of borders. Diversion happens when we don't have providers or we don't have staff. We have to just close the clinic down, or we have to just move people up the road for surgery services like all the hospitals. We have insufficient capacity for beds. We're trying to admit someone today, and I don't know how many Curtis had, but let's say 13 beds available, we needed 14. But we're 25 bed hospital, but the reason he only has 13, for instance, is staffing. He just doesn't have the nurses to staff. Salaries are just unbelievably going up, and they need to go up. Labor pool is out there, and we just can't find anyone there. Financial losses are plaguing every hospital, and we are losing money from operations, but with the pool, with the labor lift, we are able to show a small gain, which is nice. And in our hospital, I think consumer centricity is real important, which is what Tim's rolling out right now, and process changes. So let me just back up to the salaries. We're real pleased to say that we have implemented, effective today, and it will come out in the employees' paycheck tomorrow, a new salary increase, which brings all of our employees to market. We can now compete, and one of the requests of the board is we need to be able to recruit and retain. So this will allow us to recruit. We're now on a competitive level effective today with our POTEC and our SS workers, the 2 unions, with Anacortes and Port Townsend. Those are the 2 hospitals or areas that we compete with. We get a little bit broader. But for the first time in anybody's memory around here, we are now on level. So that went into effect. That's over a $90,000 a month increase. So thank you for allowing us to do that. And we've been walking around the hospital this morning. The employees are just with us being able to make that move there. We are continuing to negotiate with the POTEC and SS union. They asked for a This raise that we just put in amounts to a little north of $1 million, annualized. They want $3.5 million, so we're still negotiating with them. 3.5 would break the bank. I don't think, Kelly would be very happy if we ask him for that with our cash flow forecast. So everybody needs to realize that we are in recovery. We've stabilized the hospital and we're proceeding forward now. And soon we'll be able to move to another level. Our goal, salary wise, is to be the highest payer in the area. Our goal is to make this a wonderful place for patients to come to receive services, providers to practice, and employees to work. So on the work side, salary certainly help, and then the right culture helps. So with that, I'll end my presentation.
Any questions for Mike?
About 10 or 15, but I think I'll wait.
Compliance update. Yeah.
For compliance, we're just working on the compliance program to address the mock survey findings. And no report at this meeting.
That's short and sweet.
Thank you.
You want to do that again, just so they'll understand? Or like really to the point.
The meeting took long.
Mr. Ball has 7 questions.
So now do we have any contracts that need to be approved on the agenda? No. So basically, we need to discuss going forward with the selection for Nancy's replacement on the board. Do we have 5 candidates or 4? 5. So basically, next month for September, we're looking at moving the workshop to either the 8th or the 15th. We'll know that hopefully today, which of those dates will look the best. And then does the board want to interview the candidates at that time also? We want to get word out to them that, we want to have like 9 o'clock till 12 o'clock. Our workshop starts at 1.
Is it reasonable for us to have an interview during the daytime or during the evening? If these are people that are working or have other commitments during the daytime?
Well, we can find out.
Yeah, I mean, that's asking it on one side, but the flip side of it is that virtually every meeting that we had, except credentialing, takes place during the daytime anyhow. So if they're unable to come in for the open interview, is it appropriate for them even to apply for consideration?
So if it's okay with the board, I'll have Connor reach out to them. And then we basically set it up to where we have the candidates come in, we individually interview them.
And that'll be in an open meeting.
We'll go get back to you on that.
Possibly.
It is a rhetorical question.
She have to be determined.
Yeah. But we'll try to set it up hopefully for in the morning time, like say between 9 and noon, somewhere in that area to do the interviews with them, and then we'll be going into our work session at 1 o'clock. So that'll give us lunch. And I think, Connor, have you gotten the resumes out to all the board members? Yes. Yeah, well, it's the 5 of them. Anything else on that? Okay. So moving on to item 7, commissioner comments. We had our interviews today, and we have the CEO position. I don't know if somebody would like to make a motion. We have one of the resumes here that everybody's aware of. It'd be good to reach out and have them come out for a physical presentation to us.
Mr. Chairman, Considering the fact we initially started with 3. One of them has already obtained a position in another hospital. So timing is of the essence here. I would recommend that we invite the candidates out for a personal interview. I would recommend that we initially start with Benjamin Quinton and request that he come out to personally meet with the board.
And John will be reaching out until Mike to confirm the date because they all live out of state. So we'll hopefully get that real quick back and so we can set our workshop around that.
So I'd like to put that in the form of a motion.
I second the motion.
Maybe we need discussion. All in favor?
Aye.
Moved. Ron, do we have any public questions, comments that we need to address?
None at the moment.
Okay. And I don't think there's a need to go back into, we have it on the agenda for executive session. So at this time, we are changing the work session. It will not be on September 1st. It will be either the 8th or the 15th, and we'll get that out.
Pretty much have to be the 8th because the next one is board meeting.
Yeah. But like I said, if we need to have it ahead of the board meeting, like we did today.
You could have even the Tuesday before the board meeting, something like that. Within that.
Well, we're trying to figure this travel time, and we're gonna have them like come on a Tuesday, have them come on a Tuesday, and then Wednesday, we have several other meetings set up for that person.
Well, we'll get the help and coordinate that and get back to you.
So we'll get that out as quick as we can on the 8th or the 15th.
Yes, sir.
So the only other motion would be for a motion to adjourn.
Are you going to go through commissioner comments?
I thought that. Do we have any commissioner comments?
Is this your last meeting?
No, I'll be here in September.
There should be here to the end of September of next year.
Sure.
Well,
Nice try.
The only thing I want to say is that, because of the staffing shortage and because of the competition we have with employees, I am adamant about the fact that I think we really need to push on salaries. I would be very much in favor of looking again and looking to increase more salaries because I think the only way we're going to compete and overcome this shortage of personnel is that we become the best paid hospital in this area. And I'm adamant about the fact that if we get extra money, it needs to go back into our staff and people. I think that's how we're going to solve this staffing problem.
Well, that's kind of in Kelly's lap, and even with the wages, it's crazy out there right now. It doesn't matter what you're offering people, it doesn't, not just the medical, all across the board. You just have a hard time to get people to go to work.
But, it's tagging a little bit on to what you said. Commissioner Walker, there is something a little offensive about paying bonuses to people who are coming on staff when the staff that has been here and held the hospital together for all of these months continue to get their regular salary. And I don't know how one would reconcile that, but it's like, well, maybe I should quit and then after X number of months come back and get a bonus on top of it. It's just something that as we throw out the thoughts of bonuses and things, that we also remember those that have held the place together.
Yeah, I don't think it's so much bonuses, it's just getting the regular wages up to make it affordable.
Well, I think that's a sign of the future. It means that we're gonna have so much more inflation because it's a creep is what it's gonna be. It's just gonna be creeping. One thing, of course, is because we're a cost plus kind of organization, at least that that does gives us a little bit of cushion there, so with their staff, that's a cost that we have. And
Maybe we pay for their transportation.
Right.
You know, gas is,
But there's a lot of irony in what you say, and to meet the competition, every healthcare facility and Beyond Healthcare are all paying bonuses. What do? We not pay them and not get them? What's up?
The other big
Double-edged
thing
sword.
is providing, childcare. A lot of the people won't come back to work.
okay, Kelly, you've got your task.
Okay, so was there a motion to adjourn?
So moved.
Second,
Second, well,
discussion, questions? Are we done?
second.
Okay, all in favor?
Aye.
So moved.
Thank you.
We'll get you